Welcome to the 11 a.m. session of the HIMSS Northern California meeting. It is a great pleasure for me to present what I hope will be a wonderful panel for you all, talking about the issues around clinician burden and the impact of clinician burden on burnout for our, all of our frontline care providers. It will not come as a surprise to anyone that this is an issue that has been in place for many, many years, gradually increasing over time. And the impact of the pandemic has exacerbated a tremendous amount of the burden. We have nurses, we have providers, we have other healthcare professionals leaving the profession because of this impact. And it really behooves us all to spend substantial energy in trying to mitigate the impact of this on all our clinicians. So we're going to talk about where we are today and what we can do from an innovative perspective on improving the lives of our clinicians, the well-being, reducing the burden, and ultimately reducing the burnout that it produces. So I will go around the room. We'll start introducing our panel members and then get deep into the topic. So let me start. Michael, you want to introduce yourself?
Sure, Howard, thank you. It's a real pleasure to be here. My name is Mike Pfeffer. I am the Chief Information Officer and Associate Dean at Stanford Healthcare and Stanford School of Medicine. I'm also a hospitalist and clinical professor of medicine. And this is a really, really important topic. So I'm excited to be here on this panel.
Thank you, sir. Amrita?
Hi, everyone. I'm Amrita. I'm a combined pediatric ICU and clinical informatics fellow here at Stanford. And my research work has mostly focused around the impact of health information technology on physician well-being. And I'm really excited to be part of this panel with exceptional healthcare leaders and hope to share with you our thought processes and also learn in the process. Thank you.
All right. Thank you. And Jeff?
Thank you, Howard. Incredibly nice to be here with all of you today. And I'm the Chief Medical Information Officer at UC Davis Health, clinical professor of emergency medicine, and looking forward to learning from my colleagues today. Thank you.
Thank you, Jeff. And I'm Howard Landa. I'm the Vice President of Clinical Informatics at Sutter Health, the Chief Medical Information Officer, I think anywhere else if we use that title. And I'm also the president of the Association of Medical Directors of Information Systems, or AMDIS. I know many of you on certainly the panel, and I think many of you attending are familiar with or have been to AMDIS meetings. And it's in that context that I've been working with HIMSS for many, many years, and I thank them for their support in this. So let's get into the meat of the topic. And Amrita, I know you've done a lot of research in this area and written, and love to hear your thoughts on where we are and where we're unfortunately going. Amrita, you're on mute.
All right, Howard, thank you so much. All right, so to kick this off, I'll give you a brief summary of what we know about clinician burnout as of today and the directions and solutions, potential solutions that we can adopt to reduce this burden and burnout. Burnout was first described in clinicians in the 1990s, and over the past quarter century, symptoms of clinician burnout have risen to epidemic proportions, affecting around 50% of the physician and around 40% of the nursing populations. Unfortunately, burnout is present at even higher rates now with the COVID-19 pandemic and is related to high workload, job stress, and time pressure. Burnout is associated with decreased productivity, intent to leave practice, adverse clinician physical health, decreased patient satisfaction, increased medical errors, and costs the US healthcare system $4 to $5 billion annually. The etiologies of clinician burnout are multifactorial and likely representative of a combination of the following, as depicted in this conceptual framework, comprising of individual work demands and work environment factors. Using this framework as reference, I hope to briefly discuss the current understanding of causes and solutions around clinician burnout. Individual factors, so individual mental health, including stress, anxiety, and depression, are associated with burnout. Promoting resilience and self-care habits may be effective in reducing this burden and burnout. Health information technology related stress and frustration has also been shown to be associated with burnout and emotional exhaustion. 70% of physicians report HIT-related stress, and 30% healthcare providers report frustration with technology on majority of the days of the week. It has been noted that frustration with technology is rooted at the individual level rather than the work setting level, which suggests that individual interventions to reduce frustration with technology may be worthwhile. Coping strategies, however, for reducing stress felt to be associated with health information technology accounted for less than 2% of the variability in burnout prediction models. This suggests that there's a need to target deeply embedded root cause of burnout and a need to move away from treat the symptom approach. The lack of professional value alignment has also been identified as a potential driver of burnout. When providers in the organization felt their values were not aligned with their leaders, their odds of burning out were 3 times higher than if their values were aligned. Feeling valued is related to lower burnout scores. Therefore, strategies such as getting clinician input into quality platforms, professional development for physician leaders, etc., have been suggested as strategies to reduce burnout. Negative perception of work environment, including negative perception of electronic health records, which have now become ubiquitous in the clinical workplace, has been shown to be associated with burnout. Providers with burnout disagree that EHR improved efficiency, that EHR kept patients safe, and that EHR communications were effective. On the other hand, physicians who agreed that their organization had done a great job with EHR implementation, training, and support were twice as likely to report lower scores on burnout surveys. 50 to 80% providers report poor control over workload, which has been noted to be associated with burnout. Satisfaction with control over workload improved with EHR training, which may be a good strategy to ensure clinician autonomy and control over workload. Poor work-life balance has been associated with higher odds of burnout as well, to no surprise. However, extension of work life into home, especially in the form of EHR-related work, jeopardizes this construct. Physicians spend around 12 hours a week outside of scheduled patient time and around 5 hours every week in the evenings and weekends on the EHR. However, a recent systematic review showed equivocal results corresponding to association between this time spent outside of work hours and burnout. Organizational focus on work-life integration has been suggested to combat burnout. Moving to work demand factors, a recent study suggested that reducing work demands may have the largest impact on reducing burnout. Some of these work demands include work schedule, which includes a higher number of work hours and higher FTEs associated with more burnout. Having flexibility with one's work schedule has been associated with decreased burnout score, suggesting that perceived and realized loss of autonomy over work schedules may be contributing to this burnout. Reviewing physician schedules and appropriate interventions decrease burnout from 40 to 20% as published in a recent study. Excessive workload is associated with higher odds of burnout as well. Increased EHR-related workload in the form of objective measures such as message volume, including patient call messages volume, as well as EHR system-generated message volume, length of documentation, degree of documentation requirements, time spent on inbox and documentation have been shown to be associated with higher odds of burnout. Unfortunately, these objective EHR use measures have only worsened with the COVID pandemic. 70% of physicians attribute their administrative burdens to EHR use. This may be due to the use of clinical documentation to satisfy demands peripheral to direct patient care, such as to meet billing, quality, and compliance requirements. an unintended consequence of EHR adoption. 50% of the physicians believe they have insufficient time for documentation. This has been shown to be significantly associated with burnout as well as EHR burden scores. For every hour of physicians' direct face-to-face time with patients, nearly 2 additional hours is spent on EHR and desk work. It is imperative that this time be taken into account while thinking about physician schedules and work structures. Moving to work environment factors, organizational culture in the form of its mission, values, commitment to quality, leadership, resource allocation, and reimbursement structure has been identified as drivers of burnout. Organizational innovations were more effective than individual innovations for reducing overall burnout in a recent meta-analysis. These may include strategies such as rethinking reimbursement models for asynchronous work that we have seen really climb with the COVID pandemic, relocating administrative burden of justifying clinical care to health plans, etc. Diversity, social support, and community at work has also been shown to be associated with decreased burnout, and the current focus on diversity, equity, and inclusion should be continued. A hectic work atmosphere is one of the most cited work environment factors associated with increased burnout. Under this, workflows and processes play a major role. In a study, it was noted that burnout improved by a factor of 6 with workflow intervention changes, and by a factor of almost 5 with targeted QI projects than in controls. This was a randomized control trial. The presence of EHRs and other health information technology in the work environment has added to cognitive burden and stress owing to poor EHR usability, information overload, and slow system response times. There's also factors such as fear of missing something important and interference with patient-clinician relationship that plays a role in this relationship. Decreasing alert volume, technical enhancements to manage inbox burden, and improving EHR usability may be targets to reduce physician burnout. However, EHR design and use factors accounted for only 1 to 7% of burnout prediction model variance as compared to work culture and other work conditions, accounting for up to 38% of burnout prediction model variance. This suggests that EHR design and use factors need to be combined with other workplace initiatives to realize true reduction in burnout. Last but not the least, inefficient teamwork has been associated with burnout. The largest benefits on physician burnout resulted from interventions that promoted team-based care and incorporated the use of scribes, medical assistants, order entry clerks to complete EHR documentation. Delegating a few common tasks to scribes may be worthwhile and may help in reducing burnout. I'll stop there and I'll open it up to the other panelists for their thoughts.
Thanks so much, Amrita. You have provided us, on one hand, a kind of depressing set of statistics. But what I like is that for every area, there are potential interventions. And that's what we're really talking about. People have said that the EHR causes burnout. I respectfully disagree. I think it's the regulatory requirement, the payer requirements, all those things around us. In addition, you've called out some of the issues around safety and the cognitive burden with alerts and other information and that fear of missing something important. I think all that adds. But in each of those areas, it also provides opportunities. So I want to pivot, and I'd like to go to Michael first and ask, in his experience, both currently at Stanford and I know not too long ago at UCLA, what kind of things have you seen or what are you working on, and what is really impactful in this space?
Thanks, Howard. When I think about this space, there's a really great New England Journal article back in not too long ago, I think it's last year, that talks about how physicians, who are very motivated individuals, how that motivation changes and is dependent on 3 things really: autonomy, purpose, and mastery. And a lot of what you're hearing I think causing burnout has a lot to do with those three things not functioning at the level that physicians would want. So autonomy, right? Scheduling is a great example. And the list goes on and on and on. One of the other things I find really interesting as I think about this is some data from the Class Arch Collaborative, which I think, Amrita, you talked about a little bit. But one of the really interesting things is the relationship to burnout and leaving organizations based on how you feel the IT organization supports you. Think about that for a second, right? Not even like, is the EHR, optimized well or not, but does the IT organization care? Do they listen? And so that's really, really important. I think in how we, one way that we can combat this. The other is really focusing time for physicians individually to help them do better with kind of mastering the EHR, because it is a very, very complex tool. And, just like with anything, driving a car or whatever, you got to practice. Flying an airplane, they're all highly technical systems. So one program I wanted to highlight at Stanford Healthcare, which is something that was put in place by our Chief Medical Informatics Officer, Topher Sharp, with the informatics education team, is really a concierge program for our physicians. And it kind of functions in 4 phases, all about having a personalized, data-driven approach to helping our providers master the electronic health record. So it starts with engagement. So, just getting people excited about the program and getting a sense of their interest. Assessment, so a 30-minute observation of the providers just to see how they're performing in the system, as well as looking at efficiency data, which we're getting more and more now in the electronic health records, which can be really helpful. And then a 1 to 2 hour training session, individualized, personalized for that provider, followed by a wrap-up meeting and a 30-day survey to see how things are going. So it's a really great program. And just some of the numbers, there's 80% enrollment rate since this started back in 2016, which is really, really impressive if you think about it. And then if you look at the 30-day post-survey, the likelihood to recommend the program was at 95%. There was a 32% increase in satisfaction with the EHR and a 25% increase in satisfaction with clinical work. So that's really impressive stuff. And it really has to do with a tailored, individualized approach for each provider, showing that the organization cares. We're going to invest in this program. We're going to invest the time to give you an opportunity to, learn, and you can see success there. So I think that's really, really important. As someone in the CIO role now for way too long, I guess, we're here to make these systems usable. And I'll go beyond EHRs, right? The entire ecosystem, right? We have hundreds and hundreds of applications in the portfolio, which all of us do to really be able to deliver what we're doing. And they all have to work together. They all have to make sense. They all have to be usable. And so beyond the EHR, everything that's attached to the EHR, we need to think about simplicity and usability in everything we do, both from the IT organization standpoint and from the vendor standpoint as we bring all this together.
Thank you, Michael. Yeah, I think there's some great points there. That the concierge program is something I've seen recreated in different ways. I think we all have to give some credit to CT Lin in Colorado with his Sprint program, which is incredibly impactful, but also not inexpensive. Actually going through a clinic with a number of people, doing the kind of engagement and assessments that you talked about and the training, and then also working on the technology and doing optimizations there. But I think those are the kind of things we need to do to get past everything we're dealing with. And when we see clinicians basically dropping out of medicine, I see more articles about what else can I do except practice.
Right.
Like anything else except seeing patients, which is really why we all started in this, to see patients.
Yeah.
So it's it is more than a little disheartening to see that impact.
I agree.
All right, Jeff, what have you seen in your world that's working?
So first of all, a lot of really, good points were, raised by both Amarita and Michael here. Thank you. We certainly have learned from folks like C.T. Lin that you mentioned, and Topher Sharp, and it goes on. The University of Chicago, Northwestern in Chicago, and found that a concierge approach is the best. Our numbers are pretty similar to others that you guys have mentioned, except on the inpatient side. We're really, really good on the ambulatory side. We have worked with over 5,000 physicians now, and throughout that time, we bring the average physician about 54 minutes of time back into an 8-hour day. And that is sustainable at 30, 60, and 90 days after a 4-hour concierge session with the physicians. But, the question we have, and to this point that, Mike said about CIOs being here to make systems usable, we're probably all going to be expected to think that way going forward. So how do you get physicians ready for the impact of digital health? So fine, there's the electronic health record, but there's data coming from patients like wearables and remote monitoring. And what if research data is thrown into it? And what if search data and genotype and phenotype and patient registration data and claims data is all thrown into the same bucket? And now you have a situation where your physicians are responsible for population health. And when you spend time at organizations like AHIMA and other folks that are focused on the finance side of things, they really see a vision in the future where it's the physician that's doing the population health, because they have this real-time feed of all this data going into their phone. And let's flip AI to IA. They have intelligent assistants, whereby that intelligent assistant or assistants are able to make them more effective, and their workflows are more efficient when it comes to things like prior authorization for meds or procedures, or the bane of our existence at our campus, which is referrals, especially when referrals originate from outside our community of physicians. One point, not from the literature, but from sort of the zeitgeist out there, is Malcolm Gladwell studies about what it takes in order to be truly expert. And he talks about 10,000 hours. And if you look at the number of years for the typical electronic health record use, we're talking 20 years for a typical internal medicine physician to have expertise in using electronic health record. So at this point, we continue to sort of hone our approach, led by Melissa Jost, who is the person that leads our physician effectiveness program, and try to get better on the inpatient side. And we're doing our best to just set up ourselves for this impact of digital health and how we get doctors ready for this. As one of our doctors said, quote, "There is no time spent separately to learn technology, and this technology education needs to be installed into the system." And don't have all the answers, but we're figuring out how to address his ask.
Thanks, Jeff. Yeah, a lot of things that you've touched on are really interesting. And in my world, some of those similar problems, those referrals, both inside and outside, that mastery that you talk about, that takes 10,000 hours. And what we get constantly from our physicians and nurses is, we go and do an upgrade, or we roll out a new system and we change it. And then it's like, I want to make it better, but please don't change it. And it's really difficult, because we do keep moving the cheese. We do keep trying to figure out how to make it better. But every time we do that, we set them back at least some distance. because they have to relearn that muscle memory, that cognitive burden of, I used to know exactly how to do this, and now that is taking the place of, thought processes that we used to take care of, to provide medical care and to figure out what we're doing for the patient, are now dedicated to figuring out where to find something or how to use a tool that is supposed to help me, but certainly in some situations is getting in the way. At Sutter, I would love to talk about a concierge program and things that we do there. We've discussed it. We're not there yet. Most of what we're looking at in this area is a more broad spectrum education and offering trainings and encouraging people. The one thing that we also have found, and we're a bit of a research tool. We have some hospitals that have individuals who support the physicians at the point of care in the use of technology, and some hospitals that don't. And when we did the Arch Collaborative Survey, one of the things that really correlated well was the presence of that person who was available to help and their net EHR experience score, the net promoter score, or how satisfied people are with technology. How do you see the use of support beyond the concierge and the training to impact burden and support our clinicians? To any one of the three of you.
Yeah, well, I'll just say about the investing in people to do this, because it's clear. I mean, we've seen in the data that the more supportive the organization is, the happier the physicians are. I mean, there's a huge cost to turnover for a physician. I mean, and I've seen it estimated up to like $500,000 to, if you lose a physician and bring someone else on, the amount of time that it takes to onboard them, the interview process, the whole bit, plus all the lost productivity, getting up to speed, everything could be as much as $500,000 and may even be more. But I think we need to really understand that, like how much this turnover cost, because then you can actually say, okay, well, if I invest in these people to actually, help our providers master the electronic health record and be there when they need it, versus the cost of a turnover, I think the numbers are going to be very much in favor of support. And I think we need to think like that a little bit more, or we need to help convey that message where it needs to be conveyed. So, but and there's many ways to do that. I don't think it's a one size fits all approach, and it's going to differ at many different places. But fundamentally, the cost to keeping physicians at the organization is much more beneficial than paying for the hidden cost of turnover.
One of the things, I think this really calls it out within informatics and healthcare information technology. We always talk about people, process, and technology. And what is interesting to me is that I've got a bunch of technologists on the call, and I haven't heard very much about technology. It's a whole lot more about people and process. In looking at burnout, how do you approach it from those three pieces? Where do you think that we need to spend our time over the next couple of years within those three categories? Jeff, you want to take a shot at it?
Sure, and this is a shot. I didn't want to offer this first, but I'm sort of hearing, hidden in the messages from my panel members here, the idea of compulsory education, that you can make the case of, having education that over time becomes better and is compulsory or required, and you pay physicians in order to do that education. And we know there are, organizations, including one that Dr. Landa used to belong to, that had compulsory education for physicians. And, and there have certainly been some analysis at some levels about how, it's value added. With that in mind, and with the idea that everybody wants a digital front door, we still have a lot of challenges to the digital front door. If any of you have used chatbots and have felt like you needed to change your shirt because it's sweaty at the end of 10 minutes with a chatbot, You know, that may not be what our doctors want to use for the digital front door or our patients. And we still have the linchpin of the digital front door, which, if I may be humble, I think of as the presenting problem, because it's really, really hard when somebody's weak or dizzy or has some kind of funny chest pain or shortness of breath to really know, what the appropriate triage level is, and to be able to approach them with the right resources at the right time. So I would hope that technology would be a bigger piece. But until we work out some of these, challenges to really get to a bona fide digital front door with automaticity that is something that's ours, rather than sort of put together in bits and pieces from 100 different vendors, if I can, be, completely transparent about how it seems many people do it. I think a lot of the focus is still going to need to be on people and processes. The idea of people working at the top of their license, as far as processes are concerned, the idea of efficiency and effectiveness and reduction of unnecessary variability in our processes that we've talked about forever, but we really can do. Showing people, to Mike's point, that we really, really care. And so at this point, if I had to give a percentage, I would say it's probably 15 to 20% technology and 80%, these other important things that are people-based.
Mike, any?
Yeah, I'll just add I agree completely. I'm just going to add a different lens on this, because I've been thinking this has been a question that's asked a lot, and I would here's my answer. It depends on the problem. So every problem is going to have a different mix. For example, one of the problems I think we're all trying to solve is, how do we improve documentation? And can we get to a point where ambient, dictation technology is going to allow us to have a conversation with the patient and or family in the room and actually write a legible note based on that? And so, to me, that's a high technology percentage, right? We get that right, that's gonna be a huge win. All the way on the education side, that's much more a people thing. And then, it really just depends on the problem. And I think as we go about trying to solve all the different things that Amrita talked about, each one of them is going to have different percentages on what we do. And so that's kind of how I look at it. But I really like the framework on what problem are we trying to solve, and break it down, as opposed to well, here's a bright, shiny object, as we all like to say in IT, let's figure out how to shove it in. And then when we do that, we get to more complexity. And I think we need to get to simplicity. And if we ever get to true simplicity, then we don't need to educate people anymore, because the system just works. Yeah. And, maybe that's kind of the nirvana of all of this. Can we get to a place where the systems are so intuitive that you don't need to train people for hundreds of hours on these things?
So any technology that's sufficiently advanced becomes magic.
Right.
Hear the exact Arthur C. Clarke quote, but it's close. I'd like to leverage off that a little bit, because we have one of the I do want to get to some questions. And if you have questions, please put them in. We'd much rather talk about what you really want. So one of the questions is, other than human-driven solutions, such as the concierge services, have you seen or used solutions related to burden reduction, like voice assistance, ambient listening, real-time transcription, any others? So Mike, you started talking about some. Do you want to elaborate a little more, and let's see what other people's experience are?
Yeah, that's a great point. And the other part of the question there, which I think is really, really, really insightful, is that more technology has actually led to more people in healthcare, which is like the exact opposite of every other industry. Why is that? Well, it's kind of like, I go back to the days on paper, that was not good care. That was not the way to practice medicine. I mean, that's not the kind of, what we should be thinking of as the, better than what we have today. I mean, we had a long way, we still have a long way to go, but I think putting the technology in has really exposed areas that weren't working well, right? And that ended up needing more people to work well. So rather than, necessarily we're adding staff for technology, could it be, and this is my hypothesis, could it be that we were understaffed and the technology really kind of highlighted areas that needed more people to provide, the safe quality care that we require? Layer on top of that, Howard, something you mentioned, regulatory. I mean, the regulations, more and more and more and more regulations, that has to be accounted for in all of this. But yeah, I mean, I think when we look at technology trying to ease the burden, I think there are opportunities. And again, I think it goes back to just looking at the user experience across the board. If you're logging in to 8 systems with 9 different passwords, that's a problem, and that's frustrating, right? So you can look at everything from, foundational things all the way up to kind of dreams like, ambient dictation technology, which isn't there yet. Now, a lot of companies are working on it, so it's very exciting, but the magic right now behind ambient voice dictation is people sitting there transcribing it, which is very, very expensive, and they don't always get it right. So, that technology is not quite there yet, but it's improving. And so I think as we see these technologies that truly do solve a problem in a very successful way, then, those are going to be opportunities for us to implement that. Electronic prior authorizations, there's lots of different areas, I think, where technology could make things a little bit better. The other argument is if we make prior authorization so much easier, then everything's going to have a prior authorization, which is a terrifying thought. And then you just get even more complexity. So, hopefully the idea is that we all work together on all of this. And as we implement technologies to make things better, we don't then add on top of that new burdens and new regulations.
One thing being in informatics has taught me, the law of unintended consequences is something you really need to be cognizant of. Jeff, Amrita, any other comments on what Michael was talking about?
Yeah, just really quickly, there's so many things that we're hamstringed by from a regulatory standpoint, like this concept we learn when we're in medical school, that if it's not documented, it wasn't done. There have probably been more physicians that have burnt out over that phrase than any other single phrase. And then one of your colleagues, who isn't at Sutter anymore, Dr. Rosenbaum, working with, I won't say who the company is, but it's a CRM. When we started working with that CRM, we found that screens automatically adapt to the workflow of each individual. So the screens would be personalized, and sort of the workflow, and the software was smart enough to anticipate what someone needed in their work. So, just a couple ideas for how electronic health records could be better and the regulatory world could be better.
I'd like to just add that as a clinical informaticist, I'm optimistic about the promise of technology revolutionizing healthcare. And of course, I mean, we're not even there yet. We're just at the start of the race, but I do have hopes. And I'd like to highlight a few technological innovations and add to the list that you put forward. Things like widescreen monitors, badges to tap in and out of EHR systems, just having mobile access to electronic health record system, and note templates, order sets. All of these have definitely helped reduce EHR burden and also clinician burden, overall burden, by decreasing click fatigue and alert fatigue, and in turn impacting clinician burnout. I also came across a study recently that said that EHR improvements, when they were done to improve clinical workflows, were not as effective as EHR design changes to improve EHR workflows. So that's something that stuck with me. And I do feel like there's things that we can make happen from the technological standpoint to improve EHR burden or even health information technology burden. And there is promise.
Yeah, I think you call out a lot of relatively simple things, and it's whatever, I don't know what the inverse of death by 1,000 paper cuts is, but all those little advances that reduce cognitive burden, that make it easier to use the system, are usually impactful. I think that if we didn't have all of those, I do worry a little bit about some of the things that Michael was talking about on the ambient dictation. As a surgeon, my notes tended to be pretty short, to the point, and very information dense. Maybe not much total information, but dense. I worry that when we start including all the information that patients provide to us, how we're going to do that, what's important for this problem in this situation. I used to get a lot more fatigue from trying to read a 6-page note that only had 2 or 3 important features than creating my own 6-line note. But again, that's more the surgeon in me. I do want to, Emery, and you and Jeff both started talking down the road about things like artificial intelligence and machine learning and the capability of those things to improve burden. Haven't seen very much of that, more on the financial side, but on the clinical side, what kind of things are you hearing about or envisioning to reduce that burden that our clinicians experience? Any takers? Not much yet. Okay, well, that's not okay. Amrita, did you want to say something?
Yeah. I'd like to just say that when we talk about AI and ML helping improve EHR burden or cognitive burden, I think it's important to keep in mind that AI and ML, of course, are not going to replace clinicians or the cognitive work that clinicians do. In fact, in recent literature, there's been talk about how certain tasks may be more conducive to the application of AI and ML methodologies. Certain tasks that may offload certain clinical burden from the clinicians, example, routine administrative or clerical work. And in that field, I've seen robotic process automation come in, kind of take over clerical work that happens even before the patient meets the physician or the nurse practitioner. So I feel like AI and ML methodologies and technologies do fit into our clinical workflows. It's just a matter of us trying to figure out where they fit in best.
Yeah, we, Howard, have a team of people with PhDs that lead or collaborate with physicians to translate automatic models, machine learning models, to the clinical bedside. And it's very, very challenging, when you start to look at the Breyer scores and the areas under the curve or the C statistic and the positive predictive value of models and account for diversity, equity, and inclusion, and and make it your own. We're trying awful hard, but I wouldn't say we've been very successful in bringing a lot of models to the clinical bedside.
A lot of promise, not a lot of delivery yet.
Yeah, I would like to say one other thing, because I agree with all that. So one of the things that we've just kicked off at Stanford Healthcare is appointing a chief data scientist for Stanford Healthcare that is embedded in the IT organization. So Dr. Nigam Shah, who is an expert in artificial intelligence, a faculty member in the School of Medicine, is now joining or has joined the IT leadership team, which is really cool. And we're embedding kind of the principles of how do we solve problems with AI in how we think about everything. So it's not only just kind of, okay, well, is there a model that could
do X. It's like, is there a value? Does it make sense financially? And then how do you train the IT organization and the IT leaders to understand how this framework works? So we're really excited about this program to really start to think very, very thoughtfully and carefully about AI in clinical, financial, and operational workflows. But I do think there's significant potential there for some reduction in burden or tasks. And it's going to be essential when we start to really integrate data that Jeff was talking about at levels that are uncomprehendable by an individual person.
Yeah, there's no way we can process the information that we need to anymore.
Yep,
No.
absolutely. One phrase that we could cause all our doctors to leave: data visualization. We don't get that right. We might not have medical staff members left to work with.
Yeah.
I agree. And I'll pivot a little bit. And again, thank you all for the questions. We have a question about the industry. So what about the EHR vendors? How well do they cooperate with IT departments? How well do they cooperate with the people at the front lines of care? Are they moving to deploy the kind of technologies we're talking about? And is burden an issue for them? And do they recognize that?
Yeah, I mean, yes, they do, for sure. And I think it is a priority. It's really hard to change the cruise, the aircraft carrier. Like you said, Howard, like you start making changes all the time, in a kind of an agile software development approach. You create a lot of problems. And so add that to the fact that we all like to do things differently. So you've seen one health system, you've seen one health system. And so some of the complexity of electronic health records is the need to customize it based on individual health systems' needs. So that adds a lot of complexity. Second is the regulatory complexity of it all, which is really challenging. And then third is you can't just go make changes too rapidly because you're going to really throw everybody off. So I think those are significant barriers that we need to actually solve, I think, if we're going to really enable the EHR vendors to move faster. But I don't think they're trying to make it hard on purpose. I just don't believe that. And if we did believe that, then we're really in trouble. Mm-hmm. So I think we have to work together on all of this.
Yeah, I agree. And the thing that and we've had a little bit of experience with this recently, making some kind of a new technology available optionally and being able to maintain your old workflow, but test the new workflow, learn it when you have the time to do that, experience it when you have someone who can help you. I think that's a message that some of the vendors are getting, at least we're sending it. And I think there's a lot of potential there for getting people to actually adopt better processes and better technology instead of throwing it on them, say, this was this was your road on Friday, and guess what? Monday is entirely different.
Right.
Jeff, anything I know, from when you do upgrades, when you release new technology, any tips or tricks, or Amrita, on how we get those messages across and get people to actually use all the stuff we push out without getting them to push back on us?
Well, I love the idea of, someone having optionality. Some things in healthcare, obviously, we don't want our team members to have optionality. But this idea of being able to use, a workflow when they have the time, it's really very interesting. Not something that we've thought a lot about, and I think we need to. So thank you. The vendors have been absolutely amazing in what has been achieved. Like most IT shops, we have 400 applications between our enterprise vendor and things that support different care areas throughout the organization. And it would be nice to think that maybe that won't be the future, and that, we can have a more centralized funnel, and in the way that, that we approach things. And then we won't have such issues around interoperability, like we've all been challenged with for so many years. And to Mike's point, yeah, when we talk to the leadership of, these companies, including our enterprise EHR vendor, I think they're working really hard to try to be better and try to be more modern in their approach.
There's a question that is a little bit different, but I think it's an important one in the Q&A. Is there a correlation between the quality of training and physician burnout? Does improved training and methods delivery help reduce burnout? I've got one opinion from the Class Arch Collaborative Survey, but anybody want to comment on that?
The one thing that I'd like to mention in my review of literature is that it was noted that although EHR-related training and support helped improve control over workload, it didn't really directly correlate with improvement in burnout, which actually tells me that it's much more than just EHR training and support that's contributing to physician burnout. And there's also many other pieces of evidence out there that suggest a very similar idea, including things like work outside of work not being associated with burnout. So at this point, I do feel like there is need for EHR training for physician empowerment and ensuring that they have good control over workload, but evidence around it decreasing burnout doesn't exist in literature as far as I understand.
Yeah, I'm not sure. Okay.
Yeah, just physician builders, just as a quick concept. Very, very hard to sell here. And once the testimonials started coming out and IT was on board, because things they could never get to were being addressed, and the physician satisfaction increased greatly with information technology as a result of it. That is something in the class studies and in other literature that can make a difference.
Yeah, and I put a plug in for the Arch Classes Arch Collaborative for those who don't know about it, but it basically class actually interviews, surveys frontline clinicians. I'm very familiar with the provider side, but there's also a nursing side, and get lots of great data. But one of the things, and they do correlations because they've done this in several hundred organizations with tens of thousands of providers, and that initial training and that continued training and support certainly improves your ability to use the EHR and your satisfaction with using it. If we believe that will reduce burden, that might be a bridge too far, but it certainly reduces that cognitive load and is one more on paper cut or paper uncut in that paradigm. I'm a big believer in pulling out the elephant in the room and pointing out the elephant in the room. So we have one comment that we're all on the same EHR, and does that, we're all on Epic, and does the smaller hospital systems or those on different EHRs have different experiences? I think one of the issues is that since this is a Northern California based panel, Epic is certainly very prevalent in the area. But I'll make a comment, and I don't know if the other panelists how much exposure they have, but I've implemented Cerner, I've implemented NextGen, Sorian, and I've worked a lot with Meditech and Cerner currently on projects. I think everyone is trying. Everyone has a different take on it. I think the evolution at Cerner right now with their connection to Oracle and what seems like a new mindset of their leadership, I think it's a huge opportunity. I know Meditech, from talking to their leadership, are very interested in burden reduction and improving the way people use those systems. So I think you're getting an Epic-centric view of the world here, but I don't think that is really different for other vendors. I don't know if anybody wants to comment on that. Not sure how much experience there is out there.
Yeah, this is a long time ago, but I worked for a healthcare IT vendor for 5 years. And, that was interesting. And like Howard, I've implemented Siemens products, Envision and Sorian. In fact, I think, Howard, that's how you and I first met, was at a get together for Siemens, as well as, little things like GE and Athena and Cerner many years ago. I think it makes a difference, but I'm certainly biased by 5 years working for a vendor. And I just, my personal gut feeling from that time was everybody sort of has the same business issues, regardless of who the enterprise vendor is.
Yeah, I think it is pervasive. Interesting. We're kind of coming to the end of the hour, so an interesting question that might be our last one. Is burnout a public health problem? How do we view this? Is it something that we need to look at from a public health perspective? Would a public health approach and intervention be as useful a framework in order to avoid the multiple solutions, since the problem has been shown to be multifactorial? Amrita, you've probably done the most research in this area. I'd love to hear your thoughts on that concept.
Absolutely, yes. So the burnout being called out as a public health crisis has been concerning, because this started maybe a decade ago, and it's only gotten worse with the COVID pandemic. Research definitely points towards the pandemic worsening quality or access in terms of access to medical care. However, I do think that there's hope, and there's also avenues or solutions in terms of telehealth being one of the most promising solutions here. I do feel like getting physicians trained on use of telehealth, talking about reimbursement for these telehealth visits. All of these are impressive and very promising solutions that may help mitigate some of the burnout that we're seeing with burnout. I'm going to look at the second half of the question. Public health approach and intervention be useful as a framework in order to find multiple solutions? I do think that yes, absolutely. I do feel like we need laws and regulations around some of these technological solutions, or even processes and people solutions, so that they're adopted in a uniform manner. So I do feel like public health involvement in some of these solutions is necessary, and may help impact or reduce burnout.
Jeff, Mike, any comments?
So Howard, I just noticed that there's both a chat and a question and answer section. And there's just because of time, may have to get back to some of these questions afterwards, and we apologize for that. That's all I wanted to say. I'll hand it back to Mike.
I agree. It's a public health issue for sure. I mean, we already have a physician and nurse shortage. So this is a major issue that affects like every aspect, not just the providers personally and professionally, but the patients that rely on providers. I mean, there's nothing worse than you find a doctor that you build a relationship with and they leave because they don't like the EHR and they go somewhere else. I mean, think of all the patients that are impacted by that. So yeah, I mean, I do really like the idea of thinking of it as a public health emergency or public health problem, and thinking of it like that for, and because it really does affect everybody. And I mean, if you take this even one step higher than healthcare, right? The inability to disconnect social media and its effects. I mean, technology is, something we really need to think about in terms of how it impacts public health in every aspect, positively and negatively. But I mean, it's not just physicians who are unable to disconnect from work, but many professions, many people. So this is a huge problem beyond simply healthcare. So, but as a healthcare focus, yes, I agree. It should be viewed as a public health problem.
And based on some work I've been doing in the last few months, I mean, the number of organizations that are actively involved between CMS, the Office of the National Coordinator of Healthcare IT, AMIA, the AMA, the Electronic Health Record Vendors Association, HL7 with their integration and fire development, the Sequoia Project and the Da Vinci Project. There's so many areas that are engaged with it. More coordination would really be helpful there. And I think there's an opportunity there, but there certainly is lots of work being done everywhere. And I think people are recognizing it as a public health emergency, whether we're making that statement or not. Everyone, thank you so much. We're at the top of the hour. This has been great. I really appreciate all your thoughts, and I hope everyone got as much out of this as I did. So thank you much.
Thank you. And thank you, Howard, for leading this panel.
A pleasure. All right, take care all.